Yeah, medicine's evolved tremendously. I mean, it's involved, we've had much more in-depth knowledge about just pathology of injuries. Imaging has been phenomenal. The advent, I started here, I started as a resident in 1990. That's in the early days of MRI. And MRI is so important now in soft tissue imaging. That's been a huge change. Then in recent years, this whole area of regenerative medicine is such a hot topic. I mean, huge interest in the ability to use stem cells and other approaches that seem, novel, cutting edge, kind of sexy, but an area that needs further development. Regenerative medicine, I think, can be in the next decade. The ability to understand how can we actually improve tissue healing, but even regenerate tissue in cartilage, ligaments, tendons, and especially it's really germane to sports injuries. Taking care of the young individuals that have difficult to treat problems, tendon problems, cartilage problems, early arthritis, meniscus, spinal disc. The reality is there's very little evidence that we're truly regenerating tissue with current techniques. We can improve symptoms, and these things have potential, but it's a bit of a leap to say we're truly going to regenerate tissue. I think the potential's there, but just needs further research and further development. What we're learning is one of the fundamental issues is the inflammatory process from injury. Injury leads to inflammation, and that's, inflammation, you need it for healing, but it's kind of chronic, unresolved inflammation that can lead to adverse changes in joints. And then surgery itself, frankly, it's trauma and there's inflammation. So a lot of the research now is looking at how can we control the excessive or unresolved inflammatory process in an injured joint to prevent post-traumatic arthritis. So like the scenario you paint, the young athlete who we're going to fix their ACL, they're worried about post-traumatic arthritis later on. The best time to intervene is now, at the time of surgery, early on, at the time of injury.
Now, do you think AI or anything has any help in expediting these things?
I think AI has tremendous potential. Again, as the technology gets more and more in depth, like we can look at a single cell and look at every gene, about 36,000 different genes that are expressed in any given cell.
Wow. All right, guys, welcome to another episode of our MyoConnect podcast. Today we have Dr. Scott Rodeo, who is the head of the New York Giants team physician, and he is here at HSS. So, Dr. Rodeo, thank you so much for your time.
Thank you. Yeah, thanks for including me. Nice to be here.
So let's get right into it. So, you went to Stanford, you were a swimmer. Now, did that experience really kind of led you down this path to down orthopedic to work with high-level athletes?
I think it did. As an athlete, a swimmer at Stanford, was a swimmer growing up, and I had my own orthopedic injury, shoulder in particular, and that's kind of what got me interested in sports medicine. I had my own injuries. Actually, I remember going to see I was about 14 years old, went to see my pediatrician, I had shoulder pain. And I remember he said, I'll just take 3 months off. And I remember saying, well, I'm going to practice in an hour. You got a better idea? That's when I realized, we need better care for athletes. So that's kind of how I got involved in taking care of athletes.
So now, were you pre-med at Stanford?
I was pre-med at Stanford. Then after Stanford, came here to New York City to medical school at Weill Cornell.
Now, throughout the years since, let's say, you were in middle school when you were doing your fellowship and residency to where you are now, what have you seen change when it comes to treating and taking care of athletes?
Yeah, medicine's evolved tremendously. I mean, it's involved, we've had much more in-depth knowledge about just pathology of injuries. Imaging has been phenomenal. The advent, I started here, I started as a resident in 1990. That's in the early days of MRI. And MRI is so important now in soft tissue imaging. That's been a huge change. Another big change has been in understanding the biology of injuries. Orthopedics is traditionally plates and screws and implants and kind of the biomechanical part. Where the field's really gone the last, probably 5 to 10 years, understanding the biologic aspects, understanding growth factors and cells and the biology of injury. And at the end of the day, you're kind of combining understanding biology with biomechanics, and that's helped us really improve our treatment of injuries as well.
So I spoke to many physicians, as I mentioned to you before the podcast. So you also obviously do your surgery, but you're also part of the regenerative medicine research. So when did that, that path come about? Were you always interested in optimizing the healing post-op?
I had that interest in understanding kind of the biology of soft tissue healing. In fact, I serve as vice chair of orthopedic research here. So I run a laboratory. We've done and continue to do a lot of work understanding basic biology of healing tendons, ligaments, cartilage, meniscus. So that kind of dovetails right in with taking care of athletic injuries. You're taking care of those same type of injuries. Then in recent years, this whole area of regenerative medicine is such a hot topic. I mean, huge interest in the ability to use stem cells and other approaches that seem, novel, cutting edge, kind of sexy, but an area that needs further development. So it has tremendous potential. Honestly, what like joint replacement was our field in the 1980s. Regenerative medicine, I think, can be in the next decade. The ability to understand how can we actually improve tissue healing, but even regenerate tissue in cartilage, ligaments, tendons, and especially it's really germane to sports injuries. Taking care of the young individuals that have difficult to treat problems, tendon problems, cartilage problems, early arthritis, meniscus, spinal disc. Our existing treatments, frankly, they're not always perfect. This whole area of regenerative medicine has tremendous potential in this whole area. But at the same time, it's a lot of indiscriminate use, a lot of aggressive marketing, frankly, a lot of misinformation. Again, it's an area that has tremendous potential, but just needs further development. So one of my goals in the whole, or running our Center for Regenerative Medicine is putting together laboratory research, clinical research to really understand these treatments. Treat these patients with these things, but really follow patients carefully. Put them in a clinical registry, look at their outcomes, see what works, what doesn't work, why do things work, how do we refine our approach to using regenerative medicine?
So, what are some common misconceptions that you often hear people talk about that you say, hey, it's not accurate at all?
Actually, one of the most common misconceptions: stem cells. People, everybody talk about stem cells and want stem cells. I tell patients, I say, there are almost no true stem cells that we can use. They look at you like you have three eyes. Like, what? No, doc, I'm getting stem cells from so and so. Point is, a stem cell is a highly specialized cell by any formal cellular or molecular criteria. Now, we can use cells from bone marrow, from adipose tissue, fat, even from these perinatal formulations, amniotic tissues, placental materials, umbilical cord bloods. There are a proportion of kind of progenitor cells in those formulations that have some value, but to call it a true stem cell, that's a leap. I mean, the number of true stem cells by formal criteria is vanishingly small. And the reason this is germane is a true stem cell probably can lead to true tissue regeneration. The cell therapy approaches we use now, they are symptom modifying. They can be effective. They can improve symptoms, probably by affecting inflammation. But true tissue regeneration, that's been much more elusive. So it's kind of almost ironic. We call this area, regenerative medicine. The reality is there's very little evidence that we're truly regenerating tissue with current techniques. We can improve symptoms, and these things have potential, but it's a bit of a leap to say we're truly going to regenerate tissue. I think the potential's there, but just needs further research and further development.
Yeah, so something I often heard is, let's say I have a young athlete who just got an ACL reconstruction, right? They're always concerned, like, hey, how's my knee going to be 30 years down the road, especially if they have a B2B and all of that stuff. So what has the research been now? Like, are there like good opportunity for them to like preserve their joints so that way they don't have to get early knee replacements? Because I hear this all the time.
Yep. You hit the nail on the head for a very important topic. So ACL injury, very common, obviously. We do about 1,300 ACLs here at the hospital each year. So, and we're pretty good at getting patients back to activity. We can stabilize knee and get you back to sports. But the kind of unsolved area in ACL injury, quite honestly, is post-traumatic arthritis, just as you imply. Many studies demonstrate about 50% of patients will have some changes on X-ray at about 15 years after ACL surgery. They're not all symptomatic, but you do an ACL on a 15-year-old, 15 years later, they're 30, they're still young. Many patients will have some post-traumatic degenerative changes. What we're learning is one of the fundamental issues is the inflammatory process from injury. Injury leads to inflammation, and that's, inflammation, you need it for healing, but it's kind of chronic, unresolved inflammation that can lead to adverse changes in joints. And then surgery itself, frankly, is it's trauma and there's inflammation. So a lot of the research now is looking at how can we control the excessive or unresolved inflammatory process in an injured joint to prevent post-traumatic arthritis. So like the scenario you paint, the young athlete who we're going to fix their ACL, they're worried about post-traumatic arthritis later on. The best time to intervene is now, at the time of surgery, early on, at the time of injury. So we have some trials going on now, actually looking at various molecules and pharmacologic approaches to ameliorate or treat the inflammatory process right at the time of injury, not 15 years later when they come in with early changes in their knee.
This is interesting because I've been practicing for 10 years. 10 years ago, people weren't recommending prehab before ACL reconstruction. They just say, you're going to get surgery anyways, just do nothing. Right? But now I see, hey, 4 to 6 weeks of PT before you even get surgery, get your quad back and all of that stuff. Do you think that the way the protocol is now, based on your current research, are there going to be other things that we get to add on as soon as like someone tear the ACL?
It's a great question. That's what I think. The prehab is very important. You kind of let the inflammation resolve, get your motion back, get your quad function back. But a hot topic now also is how can you optimize the patient before surgery?
Mhm.
Can we do anything nutritionally, pharmacologically, um, activity-wise? Because and this gets like this regenerative medicine here. If you're going to draw blood to make PRP, we dietary things may affect the quality of PRP. Exercise may affect your PRP. So I think we will learn a lot in years to come. What can we do to optimize the biology of the patient there
Mhm.
prior to an intervention?
How fast do you think
Mm.
these changes can happen?
You mean as far as advancements in the
Yeah.
field, I think that the pace of change is increasing with increasing technology. I think in the next 2, 3, 4 years, you're going to have real advancements in novel, innovative therapies. Because there's a huge amount of research in this area in academia, in industry, the two working together. They're huge, huge areas of unmet clinical need.
Mhm.
As the technology gets better and better, the pace of scientific advancement gets quicker and quicker. So it's an exciting area. That's exactly what drives me to kind of run the lab program in addition to my clinical practice.
Now, do you think like
Mhm.
AI or anything has any help in like
Yeah,
expediting these things?
I think AI has tremendous potential. Again, as the technology gets more and more in depth, like we can look at a single cell and look at every gene, about 36,000 different genes that are expressed in any given cell.
Wow.
Phenomenal technology, but you have these reams of data. How do you get your arms around this data?
Mhm.
That's where AI computational approaches are helping us tremendously to use this data and to synthesize all this laboratory data with our clinical data. On the sports side, our athletic trainers and our teams have all sorts of performance data, injury data, we have imaging data, we have laboratory data. AI, we need AI tools or computational tools to put it all together to really start to draw conclusions. I think that's where it's exciting because that's why I think the pace of discovery will continue to speed up using these tools.
Mhm. So, given your experience, you're with the Giants for over 20 years now, right? And then you're also was part of the Olympic committee as well. Based on you working with high level athletes, how are those information and what you've learned in with those like super high level athlete carry over in like
Yeah.
treating like regular patient?
Yeah, I've learned a lot about taking care of athletes and patients really from working with these teams. Number one, I'll start by saying it's a team approach. We have athletic trainers and physical therapists and strength and conditioning coaches, and you're part of a team. I mean, I've learned more about sports medicine working with athletic trainers than just about anyone, quite honestly. I mean, they are with athletes all the time. So it's teamwork. I've learned the importance of you all working together as a team. Working with elite athletes, first it's an honor, it's a lot of fun, but you learn a lot from these athletes because these are highly motivated individuals. They have all the access to all the resources, rehab wise and training. So you kind of see what's the best it can be, in a perfect circumstance, and how can I use those lessons to apply it to my weekend warriors?
Mhm.
And also the athletes at that level, they're going to test your repair. I mean, if I can get an NFL player back to play after an ACL reconstruction, pretty confident I can do it with, the 17-year-old soccer player. So, these elite athletes are going to really test your repairs. I do a lot of shoulder surgery as well. Overhead athletes, swimmers, they're going to put high loads on the shoulders. So it makes you got to be on your game. I
Mhm.
mean, and so you learn from the experience taking care of these elite athletes. It informs our ability to take good care of our regular patients, our
Yeah.
weekend warriors.
So, in your opinion, because you've seen a lot of patients, what are some factors that will give them the best chance of the best outcome?
Teamwork. I think first it's really having. I always tell patients it's a team. I have to do good surgery. We need to have a good therapist, a good athletic trainer. So it's putting together the team. These athletes, and it doesn't have to be an elite athlete. It can be your recreational athlete. Grit. I mean, motivation. Part of it's the psychological part of it,
Mhm.
understanding what it's going to take to get better. That's a big deal for a high school kid. Take a 17-year-old high school athlete. ACL tear as an example, they're out for 7, 8 months. That's a big deal for that kid. Their identity sometimes is wrapped around sports. That's their social network. So part of it is working with them, understanding the kind of psychological, emotional part, quite honestly, and supporting them through that. Sometimes the surgery is almost the easy part. It's look at the big picture. How do you help support that athlete when they're in month 3, month 4? They're kind of slogging through
Mhm.
rehab. They're not quite ready to return to sports. They miss their teammates. That's not trivial,
Yeah.
especially to get into, say, a revision surgery. Now it's a second
Yeah.
season. So I think it's um, understanding the psychological part, the emotional part, being, part of it, you're their surgeon and you're a doctor, but also you're their cheerleader and you're and a team leader. You're helping them hook up with the trainer, the therapist. Sometimes they're going back to their college and work with the trainer there, and then they're home for the summer. Get them back with the therapist here. Help them make that transition from your your kind of routine post-surgical therapy to the higher level return to play metrics. You know, when you're really ready to return to play. You know, often physical therapy will get you from here to here, and you're doing well, but you need to be here for
Yeah.
elite sport. How do you bridge that gap there? Setting up the right strength and conditioning coaches, trainers, therapists. You know, it's back to teamwork, honestly.
So, what do you think is the hardest part during the, let's say, ACL, right? Because it's like you say, 9 months long.
Yeah.
What's the hardest part of that rehab process? The beginning, the middle, or the end?
You know, it's often more in the middle. Beginning, it's early post-op. They expect the pain. They expect it's going on. They expect, that they're slow. It's the middle phase when they're 4 or 5 months in, and they're kind of like, okay, this is 5 months. I'm getting tired of this. But at the same time, it's only 5 months. It's not the 9 that it takes. That's where you have to really support them, where they're starting to do some, early running and early sport-specific type of things, but they're just not ready to get back. And that's where they start to itch to start to do more functional things, but they may not be ready. Like it's a common problem you see is around month 4 or 5, they're getting tired of. It's a tedious process, and that's why it takes psychological readiness and grit. So they're at month 4 or 5. It's getting tiring, getting tedious. They want to start to do their sport specific stuff, go out and run, and start to shoot hoops or run some patterns on the football field. But they're not quite ready. If they don't quite have that base of strength, as as a therapist, they don't have that base of strength, then they kind of get a setback. The knee gets sore, they kind of get in a funk. So it's just supporting the athlete through that middle phase where they're getting there, but they're not quite there. And the rehab's getting tedious, but that's just the reality. That's just the nature of the beast. So I think it's understanding that can happen in that phase, working with their trainers, their therapists, work with the athlete. It's all about communication. I make sure I speak with the trainer and the therapist on a frequent basis. Because you're seeing the athlete 2 or 3 times a week. We only see them intermittently. So it's all about communication, get them through that hard part, that rocky part.
Yeah, I love it when you
Yeah.
give me a call because we get to discuss
Yeah,
patient,
it's
which
so
is
important.
great.
It really is.
So within the past 5 years, what I saw was an increase in the LET procedure with ACL,
Yeah,
right?
yeah.
5 years before that, it was
Mm.
not much, just straightforward. So can you speak more about that?
Yeah.
Why is it more now?
Yeah. Yeah, this lateral extra-articular tenodesis, LET, which we're learning has a role in kind of load sharing with an ACL graft. It helps control rotation. So there's a real role in protecting an ACL graft. And the concept has been out there for a while, but it's been studied more now in biomechanical models and now clinical data demonstrating that it can be effective. Not everybody needs it, but that individual with kind of generalized ligamentous laxity, hamstring grafts, they sometimes have a little more laxity. We'll see it used there more. Younger individuals, individuals getting back to contact sports, pivoting sports, high loads on the knee, that individual with kind of a generalized ligament laxity, that's where it really makes sense. And so, yeah, and the results of ACL reconstruction, although good, they're not perfect. I mean, they're not perfect. And this is an effort to help load share and protect an ACL graft. And so it's taken, becoming a prominent, part of our surgeries. Not all patients need it, but many do. Certainly in revision surgery, we'll use it more and more as well.
Is there a preference on using the ITB with the LET versus cadaver?
Yeah, typically we're using it. Most of us will do a so-called Lemaire procedure using the iliotibial band, the patient's own tissue. Cadaveric tendon would be so-called anterolateral ligament reconstruction, ALL, which is same concept and same general area. You've got a graft on the outside of the knee. Generally, we try to use the patient's own tissue and IT band, although allograft can work fine as well. I tend to use allograft for an ALL, anterolateral ligament reconstruction. In a revision setting, if the player or individual's already had an IT band harvest, even though the IT band that you harvest heals, you don't want to go reharvest that tissue. So we'll often use allograft in a revision setting, and both can be effective.
Okay. Yeah, because I've seen research like ACL with LET decrease re-tear rate
Yeah.
by pretty significantly.
It can be substantial in that, especially the younger athletes, high contact sport, pivoting sports, high loads, absolutely. The 49-year-old recreational skier may not need it. The 20-year-old kid getting back to high load activities, absolutely makes sense there.
Now, what about the BEAR procedure? Because now I see
Yeah.
people asking me about that too.
Yeah,
What are your
BEAR.
thoughts on that? And when is it? Who is it right for?
Yeah. So BEAR is actually, directly, it's a bridge enhanced ACL repair. It's actually repairing the ACL rather than reconstructing it. I think the indication is limited. You need, number one, when ACL tears, it kind of involutes, it sort of retracts. So, and it can hard to get that ligament back to bone. So BEAR needs to be done early if you're going to do it. You need to have good quality tissue. So it needs to be a tear that's right clean off the bone, not in the substance of the ligament. The reality is, even if it's a clean tear off the bone, there's usually some injury throughout the ligament. So that's one of the challenges. BEAR seems to be most, indicated in that, middle-aged recreational athlete not getting back to high-level activities. Failure rates have been found to be higher in your younger athletes, individuals get back to high loads on the knee. So it's tended to be used in that little older age group there. So I think the indications are limited. I think
Mhm.
as we learn more about the biology of ACL healing, the underlying biology of healing, we'll be able to apply better techniques for true ligament repair versus reconstruction. So now, reconstruction, of course, we're taking the ligament out and putting a graft in. So
Mhm.
in the perfect world, you would repair the ligament. We're just not quite there as far as understanding all the biologic aspects to really optimize that.
I see that
And
so much in UCL. I feel like they
yeah,
they they go UCL reconstruction and then they put the what's it called, the
internal brace.
internal
Yeah,
brace on
yeah,
it.
yeah, yeah,
Yeah, so it's
yeah,
almost like
yeah.
it's like become like the new standard. But with
Right, right.
ACL is still give or take.
Still
Uh,
evolving. Still evolving.
so last questions. I know you got to run. You're busy. I appreciate
Yeah.
your time for this.
Sure.
Tell me your favorite comeback story from an athlete that you're like, man, this has really made my day. This is why I do what I do.
Yeah. High school athlete who's had an ACL surgery, and then a recurrent tear, and then needed, complex osteotomy or a meniscus transplant.
Wow.
So you're doing a revision ACL reconstruction, but a complex knee, and it's a year-long procedure, but it's very rewarding when you get those athletes back. I mean, that's always, um, very rewarding when you because it's a challenging patient group there. They, again, missing a second scholastic season, that's a big deal for the athlete. The other is, some of the NFL guys just getting someone back to what they want to do. It's what they do because they love, but also economically. I mean,
Mhm.
it's their livelihood. So it's very gratifying seeing your athlete out there, um, whether it's ACL surgery, shoulders are done for the Giants. Um, it's very rewarding, and because you've been part of it from day one. With the NFL guys, seeing taking care of the team, you're there when the injury occurs, do the surgery, you're working with them. You see them on a regular basis, a couple times a week, even. More than your normal patient. You work with the trainers, the physical therapists. So it's rewarding to be part of the whole process and actually see it to the end when they get they're out there again. So
That's
it's an
awesome.
honor taking care of these athletes.
Yeah. Well, Dr. Rio, thank you so much for your time. I appreciate it
Sure.
that you
Thank
carve
you.
out time for us. Thank
Thank you.
you.
All right. Thank you. Thanks so
Yes.
much.